Hello, coders. Welcome to part 2 of your anesthesia guidelines and coding. We are going to finish up our PowerPoint presentation with the HCPCS modifiers, and then we're going to switch over to my notations from the CPT codebook and talk about how we code these. So the first thing that we need to keep in mind, HCPCS modifiers are added to anesthesia codes. So that's the first part. So we have two sets of modifiers we use for anesthesia. We have our physical status modifiers that we've talked about, the P modifiers, which describe the patient before they have the surgery. And then the HCPCS modifiers, which describe the circumstances of the anesthesiologist or CRNA, the certified registered nurse anesthetist. So one of the things that I always do, and we're going to see when I share my guidelines, is I write these directly in my green guidelines underneath the physical status modifiers. So they're all in one area, and I know I can always go back to them to find it. So let's talk about what each one of them means. So if we put modifier AA, this means the anesthesia was given by the anesthesiologist themselves. Versus, so we have the AA up here versus down here we have the CRNA who's directed by a physician. Okay, so again, the certified registered nurse anesthetist always works underneath either an anesthesiologist or another type of physician. So, for instance, let's say you end up working for a hospital that is relatively small in an area, and the anesthesiologist lives 45 minutes away. The CRNA is on site and they need to give anesthesia. They are going to give anesthesia directed by a physician, possibly even the surgeon performing the surgery. However, on rare occasions, we can do QZ, which is the CRNA without direction. So again, these are going to be for more emergency circumstances. Again, these are more for facilities where, snow, ice, things like that, floods, depending on the area of the country, might mean the CRNA is there by themselves and there's no direction. They're just going to do their job. Now, let's talk about this medical supervision, okay? So the QY is the anesthesiologist directing one CRNA, one nurse anesthetist, okay? So this is more of a one-on-one scenario, but this is different from medical supervision of different procedures. So one of the big things we have to keep in mind is we have outpatient anesthesia, we have inpatient anesthesia. A lot, not all, but a lot of inpatient anesthesia is going to be more of these complex modifiers we're going to talk about in a minute, okay? But when it comes to outpatient, so think like colonoscopies. A lot of people are going for routine colonoscopies. So what they'll do is, let's say we have a facility that has 4 rooms. Now, in Connecticut, the max amount of cases an anesthesiologist can have at one time is 4. So this AD, physician of medical supervision of 4+ concurrent procedures, does not happen in Connecticut. However, other states may allow anesthesiologists to use this. What this really means is that this individual, this anesthesiologist, is bouncing from room to room to room. So they're going to give patient 1 anesthesia, then go to room 2 and give them anesthesia, then go to room 3, give them anesthesia, then room 4, then they're going to go back and check on patient 1, then 2, then 3, then 4, and they're going to keep doing this as the patient goes through these smaller endoscopy-like procedures, all right? So a lot of times you're going to see QK, medical direction 2, 3, or 4 concurrent cases. And what this is really saying is that the anesthesiologist is not staying in the room with them, and they have more concurrent cases going on. So this is up to the insurance companies. Sometimes the insurance companies will reduce the amount of money, sometimes they won't. But again, it's a status of the provider. So describing where the anesthesia provider is while the patient is under anesthesia. Now, G8 is moderate anesthesia care for complex procedures. So this is when the anesthesiologist is monitoring the patient the entire time. Usually they are in the room monitoring them. Sometimes they're in the next room or they're at the computer station in the room. And again, these are going to be for, things like transplants, for people that are having infections, or for someone that's a very complex patient and they're worried about going under anesthesia. I have a friend who about 15 years ago had to have a hernia repair. It was the first time she had gone under general anesthesia, and after she went under general anesthesia, she was in a coma for 6 months because her body reacted to the anesthesia and they literally could not wake her up, and they had to wait for her body to be able to wake up naturally. So the next time she has to have any other procedures done, she either has to use moderate sedation, which is just that decreased consciousness, or they have to be really, really careful, and someone's going to be in that room with her at all times, making sure that nothing's going on physiologically in her body that would lead to another coma. So that's going to be more of the G8, okay? Complex patients with complex conditions and complex procedures. G9 is the cardiopulmonary. So these are going to be our heart and lung transplants. These are going to be what we call CABGs, coronary artery bypass grafts, where we reconnect the veins around the heart because the arteries themselves are no longer pumping blood, usually due to a fatty plaque buildup. But again, these could even be moving around, skin and muscles, doing reconstructive surgery, where the blood system can be severely involved because, again, we might also be moving around arteries and veins. So again, a little bit different between the two, cardiopulmonary versus complex. Now, the QS, the MAC, this is the regular moderate anesthesia care. Again, this is going to be for more complex cases where it might be something like it's a child and, they're only 6 weeks old. So we're going to have someone monitoring them at the same time. So again, what we need to know is what information are we getting and can we add one of these modifiers onto it? In the real world, again, it's going to be very situational, depending on the patient, depending on the provider. You might work for an anesthesiologist that works only in inpatient anesthesia, which means you may never, ever see AD or QK. You may have a provider that only is someone who does the MAC for complex procedures. So a lot of it, you want to know first, what does your provider do more commonly so you know the kinds of modifiers to look out for? And also, do they have a specialty? Are they known to specialize in severe cardiopulmonary conditions? And that will lead you to making sure you're getting the correct modifiers. Okay, so I'm switching to my guidelines. I put these in a Word document, which will be uploaded into your course. So these are the actual anesthesia guidelines. So again, remember, before each and every section of codes, you're going to have a series of green guidelines. So this is page 58. Okay, now what I've highlighted here is important information so that if I need to be reminded of what I have to do for these codes, then I can go back here. Everything is highlighted and notated. Remember, anything physically written in your code book is fair game for certification or credentialing there, but there cannot be anything pasted, taped, or stapled in. And so I'm just going to pause for a minute to let you guys know. I think I've told many of you this before. The first time I was proctoring an AAPC exam, we had a lovely lady who was taking the CPB, the Certified Professional Biller. And I went through her books and she had typed up and printed out all of her billing notes and taped it in the beginning pages of her CPT and her ICD book. And I had to rip those pages out. She was able to take them home afterwards, but she could not use them during a test. Your books will be looked through when you take the test. That is part of what the proctors have to do. And whether you're doing an AAPC exam or another credentialing or certification agency, they will look through your books. Tabs and flags are okay, like the ones that your book came with, and ones that are similar, that are small. So you can notate anywhere in your book and just tab so that you remember where that information is. Okay, so again, the first thing is we have to remember all of our anesthesia codes are 5-digit procedures. They all start with a 0. So again, anytime you see a 5-digit numeric code starting with a 0, this is anesthesia. Now, this is what it includes. So we always want to know, what do our codes include? And this is a general inclusion, which is great. It tells us these services may include but are not limited to general, regional, supplementation of local anesthesia, or other services in order to afford the patient anesthesia care deemed optimal by the anesthesiologist during any procedure. So again, something that surgeons will do sometimes is they give general anesthesia to the patient to knock them out completely. But if, let's say, they had to cut into the abdominal cavity, they may decide at the end of the procedure to do some local anesthesia around the site so the patient is relieved of pain for a little bit longer so that they can continue to heal. That's also acceptable. So again, what we're doing when we're coding these procedures is trusting the physician and, to know what their specialty is. Now, these services include usual preoperative and postoperative visits. Okay, so that is talking to the patient ahead of time, getting their full health history, understanding if they've had any issues with anesthesia in the past. The postoperative visits, excuse me, which is following up with the patient after they've had the procedure but before they wake up. And the anesthesia care during the procedure, whatever they deem optimal. Also, the usual monitoring services. These are the machines they're hooked up to. The ECG, so the electrocardiography, so looking at her heart. Temperature, of course, blood pressure, oximetry, so seeing how much oxygen is in the blood. Capnography, which goes along with it. So we want to know how much oxygen the patient's getting in and how much carbon dioxide they're releasing to make sure that they're breathing properly. And mass spectrometry, again, which is looking at that amount. So we're also looking at how much the patient's physically breathing out. That's the spectrometry. So if you've ever had to breathe into a machine because you had asthma or bronchitis or pneumonia, it's similar to that, but it's all captured in the same piece of equipment, which is really neat. So that's all included. None of those can be reported separately. Unusual forms of monitoring like intra-arterial, central venous, and Swan's-Ganz are not included. Those are different types of catheters that we stick into a system. So intra-arterial, into an artery, central venous, which is going into one of the main veins in the upper arms, upper shoulders, or chest. And Swan's-Ganz a lot of times goes into a larger vein like the femoral vein in the leg. Those can be coded separately because it's considered separate from the package. Okay, so what is included, what is not included. Okay, it then goes down, and you can see down here. Okay, now the reason why we have this notation to report moderate or conscious sedation provided by a physician who is also performing the services for which conscious sedation is being provided, see codes 99151, 152, and 153. So the reason why they have this notation and the following notation is because if you go back and you look in a 2016 CPT book, you're going to find that we had something called the bullseye, okay? And the bullseye meant that that procedure included moderate sedation, but there were so many problems with billing for it that eventually the doctors and the anesthesiologists said, you know what, we need to just create their own set of codes. So we will go over this code set, 99151 to 99157, when we do medicine, because it's in the back of the book. So this is only for anesthesia services. Okay. Now we talked about this. Again, time is usually in 15-minute increments, but as it tells us, time for anesthesia procedures may be reported as customary in the local area. I know for most of New England, we use 15-minute increments, but that's always a great question to ask. If you're going to go for an interview for anesthesia, you could say, do you use 15-minute time increments or do you use another customary time? And that will show that, again, you have better knowledge of this code set. This is important. Remember, anesthesia time begins when the anesthesiologist begins to prepare the patient for an induction of anesthesia in the operating room or other equivalent area. So as soon as the anesthesiologist or CRNA, just because they don't say CRNA doesn't mean that they're not included in this, when they walk in the room and grab the anesthesia they're going to give the patient, that's when time starts, okay? And it ends when the anesthesiologist is no longer in personal attendance. That is when the patient may be safely placed under postoperative supervision. So time ends when they hand it off to the nursing staff, either to go back to the patient's room or the recovery area. So anesthesiologists, remember, they get paid for every minute. They don't get paid for every second. So it doesn't matter. We always round to the closest minute. If they said they did 47 minutes and 2 seconds, it's 47 minutes. Okay, that's it. We don't round up. And it's also up to them to tell us that they did a certain amount of minutes. And they have a checkoff sheet, by the way, that they monitor the patient with. So they do help us with all of this, but they have to provide documentation. Again, they remind us that services rendered in other areas use E&M service. So again, if a doctor, like a primary care doctor, decides that they are going to take a ward off of someone's hand and they use local anesthesia, that is not from this section, okay? This is just for our anesthesiologists and CRNAs when the patient is in an ambulatory surgical center or in the hospital. Now again, supplies and materials, what are included? Supplies and materials like sterile trays and drugs over and above those usually included with an office visit or other services may be listed separately, okay? So again, over and above. So the bandaging that we're providing for that patient that we just took the wart off their hand, okay, that is included. But if, let's say, we're going to give them 10 4x4 non-stick bandages and 10 rolls of gauze, that can be coded for the patient because we're giving them their supplies, and those are above and beyond what we normally use. And we do have a supply code 99070 for that. We also have a whole series of HCPCS codes to get into more specifics of what we gave to the patient. As it goes on, separate or multiple procedures. So remember, when multiple surgical procedures are performed during the single anesthetic administration, meaning the patient is not waking up and going back to sleep, the anesthesia code representing the most complex procedure is reported. The time reported is the combined total for all procedures. So you can see I have a little note I put down here. Okay, my note says only one code for multiple procedures, coding based off of most complex procedure. And how do we know that? Because again, remember, the relative value guide has the numbers in them. Each procedure in anesthesia has a number associated with it. And again, that is the base unit. We're going to code for the highest base unit, but combine all of the time. So again, if let's say we do a sinus reduction, okay, and of the ethmoid sinus, let's say, and we do a tonsillectomy, those are two separate codes. Whichever one has the highest base unit is what we're going to use, and we would combine all the time for that procedure. Now again, if for some reason we do something unusual, like say for my friend there, where they say, listen, we want to try this new anesthesia because we think that you won't have that reaction. That's where the special report comes in. Remember, special reports is a service that is rarely provided, unusual, variable, or new, and may require a special report. Pertinent information should include adequate definition or description of the nature, extent, and need for the procedure, and time, effort, and equipment necessary to provide the service. So the anesthesiologist for my friend would describe her history, why it's important we try this, the reason we did it, the need for it, the effort they put in, the equipment they put in, and then it would hopefully get paid by insurance. Okay, so now we're looking at the next page. We're looking at the physical status modifiers. Okay, so let's talk about, again, the differences between them. A normal healthy patient is a normal healthy patient, even if they're getting something removed, okay? So if someone goes in to get their gallbladder removed, but otherwise they're normal and healthy, they're still a P1. A P2, the mild systemic disease, again, this is like a chronic disease that's controlled. Controlled asthma, controlled hypertension, controlled diabetes. Again, controlled by either like diet or exercise or medication or another type of treatment. A P3, severe systemic disease, this is multiple chronic conditions and chronic conditions that are uncontrolled. So again, uncontrolled hypertension, uncontrolled diabetes. P4, again, is a constant threat to life. So their systemic disease is putting them in a constant threat to life. So again, this is going to be like congestive heart failure. This could be, emphysema, chronic obstructive pulmonary disease, okay? A P5 is a moribund patient. Remember, moribund is not expected to survive. So this is someone who is dying. So this is going to be a combination of even different types of cancers, different infections. This also could be traumatic accidents and injuries. And then remember that P6 is for brain dead patients because we do not have proper proof that brain dead patients do not have physical feelings. So they get anesthetized before their organs are harvested. As we go down, again, they remind us that these 6 levels are consistent with the ASA, the American Society of Anesthesiologists, okay? And so right here, the example is, if we were to handwrite it out, 00100-P1. Remember, in most computer systems, the CPT code and the modifier are separate boxes, so you would not put that dash in. Okay. Let's look at our qualifying circumstances. So these are next to our physical status modifiers. Again, more than one qualifying circumstance may be selected because, again, multiple of these conditions can be happening in the same patient at the same time. So again, they talk about the importance of describing these patients. 99100 is for children younger than 1 and people older than 70. 99116 is, again, the utilization of total body hypothermia, cooling the body down. Again, we do this usually to help tissue survive, especially after things like heart attacks in younger patients. Again, controlled hypotension, where we use a lot when we're dealing with our cardiopulmonary system. We want to thin out the blood so that we can continue doing the surgery safely. And then 99140, complicated by emergency conditions. And as they tell us, an emergency is defined as existing when a delay in treatment of the patient would lead to a significant increase in threat to life or body part. Again, think accidents, injuries, crush injuries, things like that, where you have to get them into surgery right now. One of the things that you've noticed, if you've been under anesthesia or someone you know has been under anesthesia, is that you're not allowed to eat or drink anything ahead of time because they don't want you to aspirate and have any liquids coming up your throat and getting into your respiratory tract. However, if it's an emergency, it's an emergency. And if they have to take you in, that makes it more complicated. They have to monitor you much more closely, especially if the person just ate. So now let me show you, these are the notations that I put down here, okay? So the HCPCS modifiers, I make my own little notations here. You can see I have the AAAD, QK, QX, QY, QZ. I've also written the types of anesthesia, and I've written the anesthesia calculation, which with its importance on the B, T, M, and C. So again, this I was able to fit right on page 59 under the P status modifiers and the qualifying circumstances. And so again, you guys can always bring this up in the Word document, which I'm going to upload into your course so that you can see my notations. Well, let's talk about coding. Okay, so when we're coding these, this is what the codes look like. So if we go back, again, we're going to have indented and standalone codes. We also have some add-on codes too. So again, the code setup is going to be the similar for basically the rest of the book, with the exception of medicine a little bit, because medicine has some codes that do look similar to evaluation and management. So again, we need to be careful, like 00320. Anesthesia for all procedures on esophagus, thyroid, larynx, trachea, and lymphatic system of neck, not otherwise specified, age 1 year or older. Okay, so again, this one has an age definition. Its indented code would read anesthesia for all procedures on esophagus, thyroid, larynx, trachea, and lymphatic system of neck, needle biopsy of thyroid. Remember, we stop reading right where we get to the semicolon, and then we go down to the indented code. But right down here, 00326, anesthesia for all procedures on the larynx and trachea of children younger than 1 year of age. Okay, and you can see in the notation, do not report 00326 in conjunction with 99100. So this is one of these things that we have to keep in mind from now to the rest of the CPT book. If the code describes a modifier or an add-on code, we cannot then use the modifier or add-on code. So because this procedure says younger than 1 year of age and add-on code 99100 says that is for procedures on children younger than 1 year of age, we can't use them together. That's considered what we call double dipping or double billing. So again, a lot of times there's these do not reports. Always read the notations underneath your codes to make sure you're in the right spot. So this is what they look like, and they're separated out by anatomic site. But when we're looking at them in the back of the book, now this is something that drives me a little bonkers, because on the tiny bottom of page 823, the main term of anesthesia starts. But the only procedure under this is the Abies-Lander procedure, okay, which is something that we do for the skin of the face. So the rest of these codes end up on the next page and the page after. So this is what I was saying going back to week 1. Everything is always above and to the left. So when we flip to the next page, you'll see up at the top it still says anesthesia. All of these subterms are under the main term of anesthesia. So when we're looking for an anesthesia code, we can look under one of two main ways. We can go anesthesia and then the anatomic site, or we can do anesthesia and then the procedure. So for instance, if I'm looking for a procedure for anesthesia on the anus, I'm going to go to anesthesia, and then I'm going to come down here in alphabetical order until I see the word anus. And then I'm going to go to code 00902, and I'm going to double check that that is the procedure I am looking for, okay? But be careful, because sometimes it gives you more than one code. If we were in fact looking for a procedure on the lower arm, we would go to anesthesia arm lower. You can see here we've got a whole series of codes we'd have to look into, because for the anus there's only one procedure code we use. For the lower arm there are multiple, so we would have to look through and match up the anesthesia with the procedure. Okay, but we can also look up the procedure name itself, like amniocentesis. This is what we do when mom is less than 3 months pregnant, and we're looking for things like the trisomies, and we're getting that amniotic fluid. You can also look under stuff like cleft lip repair, cleft palate repair, childbirth. So again, different ways of looking these up, but we always start with the main term of anesthesia, the subterm of either the body part or the procedure itself. And then if the example gives you information, you will then put in the physical status modifiers, HCPCS modifiers, or qualifying circumstances. Okay, guys, so this will be uploaded into your weeks for you. If you have any questions, please let me know, and have a great day.